now it is my great pleasure to introduce the next speaker, Dr. Dimitrios Kafetzis, another leading figure in reproductive medicine, who will talk to us about immunological factors in recurrent implantation failure, facts versus fiction. Please, Dimitrios, the floor is yours.
Thank you, thank you. I have to say that it is an immense pleasure to be here today and talk in front of all of you. Usually the first question I ask, I try to show off and I say, how many of you are fertility experts? Now today I'm humble because all the gurus are here, so I cannot ask that question, but I'll try to make the presentation as fun as possible. So this is us, a small boutique clinic in Dubai, started a few years ago. In the front row here, the two bosses of my life are sitting. First one is my wife that rules the house, and whoever man of you here say the opposite, you're actually mistaken. And the next is the lab director, Dr. Maria. She rules the clinic. So I'm in a big honor to have them here today. I have nothing to disclose, and this will have a great role to play to what I'm going to tell you today. So the father of all our Western thinking is this guy, who actually didn't write anything down. As all of you know, Plato wrote everything down for him. And it always amazes me how it takes us something like in historically it takes us over 20 years to adopt anything new. As you can see here in ESRE, if you go to the red, it shows that none of the testing and treatments for anything to do with immunology is currently considered acceptable. And it really ceases, never ceases to amaze me that the Americans, being always ahead of us and one step ahead of us, they still think that we shouldn't be testing. And they say that immunotherapies are actually of uncertain benefits and actually might be causing risks. I'm just checking the time. Now, the papers from Paul and Baris, do they make us lazier? Is it easier to sit in front of a couple that failed after a euploid embryo transfer and tell them, don't worry, it's fine, let's transfer another one? And then if they say, doctor, I'm 43, I don't have another one. Like, you should have done better before. Like, how do you reply to that? You stimulate her again. She might need another 10 stimulations to get another euploid embryo if she's going to take, so to get. So we have to be, I love this paper, it came out, I said, okay, good, I'm fine. I'll do all my follow-ups for failed attempts and say sorry, but it doesn't work like that. It doesn't work like that in the real world. Attilio said it yesterday, like the more the general team of doctors doesn't do hysteroscopies, the more he will do, the more glory he will get, and the richer he will become. So you can't stop the truth. You can't sit in the front of a couple and say, with the first transfer, euploid embryo, we get 60%. No, we shouldn't be getting 60%. I'm sorry. I'm sorry. So that's the end of my talk. If you're looking facts versus fiction, that's my topic today. I don't have any RCTs to show you why immunology is actually important for implanting of a euploid embryo. So, heretic, a Greek word. Someone has an opinion. What is the opposite of against the popular opinion? Thank God, because of pioneers like Attilio, like Sergio, like Luis Alonso, we're now starting slowly to think, maybe a hysteroscopy before transferring a euploid embryo. And still, many doctors don't believe it. And what do we do with heretics? We stone them. Now, why should I tell you the trade secrets? Why should I tell you what we are doing if you're not going to believe, and if in the private sector, the next clinic next to me is going to actually match my pregnancy rates? I don't know, but because Attilio is a good friend, I decided to come here. He told me actually not to post this picture of him because he says he's much slimmer now, he has a six-pack. But the honest answer is that what Dr. Perry just said, there's no way you're going to do a hysteroscopy to 100 women and you will not find unexpected findings. There is no way. There is no way. And whoever does hysteroscopies knows. And yesterday I was listening to talks like, oh, I'm such a good sonographer that there's no pathology in the uterus that I will ever miss. Okay, mate. What can I say? Even if you actually dilate the cervical canal and do your transfer 10 times more easily, that the hysteroscopy worked. Like whoever does day-to-day IVF knows that. So to say, we will not actually do a hysteroscopy, I think it's a joke. And I'll tell you a story here. I was talking to one of the authors of the famous hysteroscopy trial that said it's not necessary back in the UK. And he said, are you joking? In my private setting, I do hysteroscopy for everyone. This was just for the NHS. Like, this is who we are. I'm sorry. And I am not the best IVF specialist in the world, and neither are you. So have a little bit of fear. Say, well, I don't know everything. This is my hometown, by the way, and the building in the pink is my high school. The ancient theater was built by Philip, and my town was built by Philip, the father of Alexander the Great. But I wish I had a fraction of his courage. I'm so scared. And then when I first gave my dissertation paper for IVIG, for recurrent miscarriage in 2011, and I tried to publish it, of course, nobody accepted. Back then, only the Danish group by Christensen were giving IVIG for recurrent miscarriages after natural conceptions. Then my poster was the first in ESRA in Munich for intralipids. Since then, it's slowly becoming more and more popular. But people are telling us, how do you get these pregnancy rates? And these are real pregnancy rates, not like, we keep the poor responders, not like, one follicle we will not collect. No, endometriosis and adenomyosis, let's actually put them in another group. No, these are real clinical pregnancy rates from last year. If you can get better than this, good. But don't tell me that I will just be doing euploid transfers. For those of you who know Ari Kumarasamy, you know how he doesn't care about anything but data and hard data, because whatever he publishes is adopted by the NHS immediately, apart from this. Apart from this study that just came out 2 months ago and said actually that we should be thinking more about any of these treatments that all of us so easily dismiss today. Look, women 38.5 previous failed ART cycles, and they got significantly better results than actually not treating. So 27,000 cycles tested, 5,000 had immunomodulation treatment. I don't know. I don't know what more to give you to believe, apart from the fact that in our clinic we are actually testing for whatever is there to be tested, and we're constantly looking for new labs in Spain and in Europe and in the US. So we take one sample and we send to different labs at a specific time of the cycle, plus tests in the serum, in order to be able to give the couple, prior to the first embryo transfer, the best chance that they have. I'm actually excited about this new test. I don't know, probably most of you know about it. that they promise very, very high specificity, and I hope it will save us some diagnostic laparoscopies, because as you all know, endometriosis is directly related with immunomodulation and blockage of the progesterone receptors. We are also blessed in Dubai to be working in the same building with one of the most famous reproductive immunologist doctors in the UK, Dr. Bhavna Khan. And we have also professors of hematology in the same building. So any couple that we have been suspecting, even before the first euploid embryo transfer, that they might have anything in their family, anything in their personal history about thrombophilia or immunology, straight to the experts, not to us, we're not the experts of immunology, to test the serum. The endometrium is ours. The serum is for the immunologists. So, and going from there, Dr. Bhavna actually showed me some studies a few years ago about the hydroxychloroquine and how we can slowly implement it for couples that we find something in the serum in terms of immunological anti-DNS, anti-RO antibodies. So we have been working well with that regime. And this is one of the cases that went well. So one lady with one only embryo, and she came to us to say, yeah, let's bank another embryo. And then, of course, we got too cocky and said, yes, let's bank another embryo. Then she got PID, ended up in the hospital, and with IV antibiotics. Then Professor Vattier did her follow-up laparoscopy, and he called me to say, well, it was a small disaster, but we managed in the end. So because of her endometriosis, we gave her 3 months of GnRH, and because of Dr. Bhavna finding abnormal antibodies, we gave her hydroxychloroquine. She's actually now over 14, 15 weeks. And to go a little bit further with Dr. Parry's discussion, this is a couple we haven't transferred yet, and I want to ask you how many of you would actually transfer an embryo in this endometrium for a lady that doesn't have any other pathology. It's actually a male factor, infertility. I bet 10 out of 10 would say, yeah, this is a nice endometrium, but it actually isn't. It isn't. So who can convince us that this woman didn't need hysteroscopy? 1 failed IVF, 2 euploid embryos, and we would have sacrificed them both before knowing that she will actually need, like she has chronic endometritis. So the answers will come. It will take more time. By the way, lately, I stopped reading studies that don't involve euploid embryos. It doesn't make sense anymore. Of course, I read all, and for untested embryos, for a study to convince me that untested embryos numbers make a difference, it has to be over 10,000 cases. But for euploid studies, see, these are the only 2 that I would find on HLA. So the answers will come, but it will take more time. Do we have this time? Our couples certainly don't have this time. So Socrates was also known for his obstetric method, and all of you being obstetricians, you probably know that he wasn't giving any direct answers to his students. He was asking them the right questions so that from the answers they would say, ah, yes, 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 master. So I want to ask you, we don't have the tests that are accurate. We don't have the ascites. The add-on treatments that we all blame, they don't do any harm. So there is evidence saying that probably they might be making a difference. So would you give them? The answer is yours. So I cannot accept, going back to the ESRE, that we would have to sacrifice 2, 3 euploid embryos before we start looking a little bit deeper. So anything in the history of the lady that implies testing, please don't transfer. Test. Inform the couple that we have the testing. We can do hysteroscopy. Offer, as we used to say in the NHS. If they don't want to do, it's their issue, but offer. Initiate the investigations if you fail. Don't wait for 2 or 3 embryos. And then back to the nuclear-powered Attilio, please do a hysteroscopy. It's 10 seconds. It's 10 seconds. And now is the real time for questions, and thank you very much.